everyone, and welcome to Cure Talks Innovator Series with CLR. I'm Shweta Mishra, and today we are discussing the use of CLR 131 and other targeted radiotherapeutics in pediatric cancers. Joining me on the patient advocates panel are Jeremy Piver and Mark Unger. The featured experts we have with us are Dr. Mario Otto and Dr. Daniel Morgenstern. Dr. Otto is Associate Professor in the Division of Pediatric Hematology, Oncology, and Bone Marrow Transplant at the University of Wisconsin School of Medicine and Public Health. Dr. Morgenstern is the Director of New Agent and Innovative Therapy Program and Therapeutic MIBG Program and Co-Director of Neuroblastoma Program at the Department of Hematology Oncology at Sick Kids, the Hospital for Sick Children associated with the University of Toronto. I extend a very warm welcome to the panel here, and thank you everybody for taking the time to join us on Cure Talks today. Dr. Otto, I will start with you, and I request you to begin with by giving us a little bit of a background about the drug CLR 131 and help us understand its unique mechanism of action.
Well, thanks, Shweta. This is a very nice opportunity to join this panel here and present a little bit more about this drug. And this type of drugs, or these types of drugs that we are now more and more using in pediatric oncology. Now, CLR 131 is chemically speaking a radioactively labeled so-called phospholipid ether analog, also called a PLE. And for almost 4 decades, it has been very well known that naturally occurring PLE selectively accumulate in human cancer cells compared to normal cells. And further research on phospholipid ethers and their derivatives led to the development of PLE analogs, which improved tumor retention and pharmacokinetic properties. And one of which was CLR 1404, which is the parent molecule of the drug CLR 131. The mechanism of how these PLE analogs target tumor cells is actually quite fascinating. So these PLE analogs enter cancer cells via so-called lipid rafts. And lipid rafts are specialized plasma membrane microdomains that are rich in cholesterol and sphingolipids, sphingomyelin, which organize spatially signaling pathways and regulate cell proliferation and survival. And lipid rafts are much more abundant in cancer cells than in normal cells, likely due to the higher metabolic and signaling requirements in cancer cells. And lipid rafts serve therefore as a cellular portal of entry of CLR into tumors. And once CLR 131 is in the tumor cell or other PLEs as well, the drug is rapidly internalized and integrated into cell membranes and into intracellular membranes. And because cancer cells, in contrast to normal cells, have a relative lack of enzymes that degrade and metabolize these PLE, there's a high retention of CLR 131 in cancer cells. In CLR 131, the radioisotope iodine 131 is covalently bound to the phospholipid ether as the cancer targeting moiety. And we call this actually a phospholipid drug conjugate, or PDC. And CLR 131 delivers iodine 131 to cancer cells for targeted radiotherapy with fairly high specificity. The uniqueness of this drug and drug family is its almost universal uptake in cancer cells, including pediatric and adult solid tumors, brain tumors, cancers of the blood system, such as multiple myeloma as well. And essential for the treatment of brain tumors, this drug crosses the blood-brain barrier, and uptake of the drug has been shown in a variety of brain cancers. Now, my lab here in Wisconsin has shown uptake and retention, as well as therapeutic efficacy in preclinical animal models of the pediatric cancers, neuroblastoma, rhabdomyosarcoma, Ewing sarcoma, and osteosarcoma. And a single dose of CLR 131 led to slowing of tumor progression and prolonged survival in these animal models, while the treatment was overall very well tolerated. And uptake, as I mentioned before, was also shown for various brain tumor cell lines and xenografts, such as medulloblastoma, glioblastoma, and atypical teratoid rhabdoid tumor. And these preclinical data provided the rationale for the ongoing phase 1 study in children and adolescents with relapsed refractory cancers.
Right. Thank you, Dr. Otto. That was laid out very clearly and comprehensively. I'll move to Dr. Morgenstern now. Dr. Morgenstern, it would be great if you could give us an overview about the current standards of care for pediatric tumors.
Thanks. So that's a huge question and a huge topic to take on board. I think the way to think about it is to just talk about the context in which we are exploring the use of CLR 131 at the moment, which is that for most childhood cancers, when they first present, we already have standard treatment protocols for those diseases, which often incorporate combinations of different chemotherapy medicines that might be given intravenously or orally, that often incorporate surgery, especially of solid tumors and brain tumors, and may incorporate external beam radiotherapy, which is when we use X-ray treatment to deliver radiation to the tumor with a beam shone in from outside the body. And then for patients whose disease does not respond to these first-line treatments, or whose disease recurs after initial treatment, that's when we as clinicians begin to explore more experimental options. And that's when we might begin to talk to families about early phase clinical trials, which means testing drugs that are a much earlier stage of development. The first stage of development for new drugs is called a phase 1 study, where we're really focusing on the dose and the side effects of the drug and whether it's safe and whether it's tolerable to give to patients. And that's the stage that we're currently at with CLR 131. So at the moment, the patients for whom this drug would be relevant are really those patients whose disease has not responded to the other available standard therapies, and for whom really we're looking for novel approaches. I think we're very hopeful that new drugs like CLR 131 will be helpful against pediatric cancers. But it's important to say that the fact that this is a phase 1 study at the moment means that we're just at the beginnings of learning about its use in the clinic. And it's really too early to say, oh, this is a drug that works and these are the patients that we should give it for.
Of course, yeah. Thank you, Doctor. Dr. Otto, let's talk about the clinical trials related to CLR 131. So what are the results that we are seeing so far in the phase 1 clinical trial study of CLR 131 for pediatric cancers?
Sure. Now, as Dr. Morgenstern just pointed out, CLOVER 2 is a phase 1 dose escalation study for children with relapsed or refractory extracranial solid tumors, lymphomas, and brain tumors. So because it's an ongoing study, the majority of the data has not yet been released. However, my colleague, Dr. Diane Puccetti, presented the first preliminary and safety data on 7 patients with malignant brain tumors treated with CLR 131 at the most recent International Society of Pediatric Neuro-Oncology meeting in 2020. And these patients received a single dose of 15 millicurie per square meter or 30 millicurie per square meter, up to 60 millicurie per square meter. And actually 1 patient received 2 doses. And the median age for those patients was 10 years with a range of 6 to 15. And these patients had a median prior line of therapy of 2 with a range of 1 to 8. And the diagnosis included diffuse intrinsic pontine glioma, or DIPG, ependymoma, glioblastoma, and medulloblastoma. And the most common side effects that were noted are adverse events, grade 1 to 2, so lower grade, that were reported by patients were fatigue, headaches, nausea, and vomiting, and up to about 50% of the patients. These side effects were all temporary and resolved spontaneously or with supportive care measures fairly quickly. As expected also from a radiopharmaceutical, the treatment was associated with grade 3 to 4 neutropenia. That means low ANC count or neutrophil count, and also about half of the patients, and thrombocytopenia, which means low platelet counts. Also about half of the patients experienced that, which temporarily required either platelet transfusions or support of neutrophils with growth factor. This is in line with the data from adult trials where cytopenias are the most commonly reported adverse events. And however, the Data Safety Monitoring Committee deemed all of these completed dose levels as safe, and hence dose escalation is ongoing.
Thank you, Doctor. So could you talk a little bit more detail about who is eligible to receive this drug?
Yeah, so let me probably start perhaps with telling a little bit about the trial design. I think that's also very important. So the study is a two-part non-randomized open-label study. And for the patients that I just mentioned, and the study is available at sites here in the US, in Canada and Australia. And part A is what we call the dose escalation study with up to approximately 20 patients that will be enrolled. And I mentioned also the trial started initially with the first dose or lowest dose of 50 millicurie per square meter. And then subsequent doses will increase by 50 millicuries per square meter. And if tolerated, and the data monitoring committee feels this is all safe, we'll accelerate to the next dose level. And when we get to dose levels of 60 millicurie and above, we'll actually split these dose levels in two fractionated doses about 15 days apart. And that is based on the experience in adults where the bone marrow suppression is much less when you split the doses in two, or the dose in two, about 14, 15 days apart, while not affecting the efficacy. Patients who do not experience dose-limiting toxicity can be also retreated twice with CLR 131 at the same dose level that they were assigned previously. And we can initiate retreatment by 65 to 125 days after the previous infusion if eligible. Now, you mentioned the question who's actually eligible to receive the drug. That's very, of course, important. So main criteria, it has to be patients between 2 and 25 years of age. It is a pediatric trial. And the reason why we can't treat patients that are younger than that is a practical one, because patients need to be isolated in an MIBG room, as is basically a lead shielded room. And that would not work with very small infants. Then, of course, patients all have to have histologically confirmed relapsed or refractory pediatric solid tumors or lymphoma or malignant brain tumors that without standard treatments options with curative potential. And all patients have to have also an appropriate performance score. We call this Lansky or Karnofsky of 60 or higher. Patients also must meet specific laboratory criteria. They are hematological, liver function, and kidney function, for instance. And patients also, some patients may have had an autologous stem cell transplant, and even some fewer patients, even an allogeneic stem cell transplant. They have to be at least 3 months from that transplant before they're eligible for the trial. Important also that patients must be able to commit and take thyroid protection. It's radioactive iodine that can also affect the thyroid gland. And very importantly as well, the patient must have an autologous stem cell backup available when receiving doses greater than 30 millicuries per square meter, and we must be able to collect such a backup before starting the treatment. Important also that female patients of childbearing potential must be, of course, not pregnant and practice an effective method of birth control. And important also for patients with solid tumors and brain tumors, they must have at least one measurable lesion with the longest diameter of at least 10 millimeter or a centimeter, or a PET MIBG avid lesion that we can follow. There are some major exclusion criteria. For instance, patients with neuroblastoma may not have received or would exceed a lifetime dose of 54 millicuries per kilo of MIBG, which is very rare to actually happen. So most patients probably will still qualify. And obviously they can't have a concomitant severe illness or organ dysfunction that could interfere with the trial or the trial conduct. The other important things are major surgery cannot have happened within 6 weeks of enrollment, and any anti-tumor therapy or investigational treatment within 2 weeks of dosing must have stopped 2 weeks before enrollment, and that includes also large area radiation within 3 months. However, palliative focal irradiation is not an exclusion criteria.
Okay.
So maybe I could just highlight a couple of things from what Dr. Otto has just said, because I think in some ways this study is a little bit different from other standard phase 1 studies of anti-cancer drugs, because most of those are given by mouth or IV on a continuous rolling basis, whereas this is, as we've discussed, either one infusion or that infusion split in two. And so the process is a little bit different in terms of the overall flow of time on study. And I think the other things that are really important to understand is this requirement of having available stem cells before patients are treated can be a challenge, because there are some diseases like some brain tumors and neuroblastoma where we would routinely collect the patient's own stem cells and may have them available in the freezer already. And there are many other diseases where we would not have those cells available. And so for patients to be treated on study, they would need to be have their stem cells mobilized and then harvested before they could be treated. So it's a little bit of a different undertaking than joining a drug study. And then, as we've already mentioned, the treatment itself is radiation, but actually, unlike standard external beam radiation, it's radiation that then sits inside the body and then needs to come out and comes out over a little bit of time after the treatment, which means at least initially patients need to be treated in a special facility, and as we've discussed, a lead-lined room, which is one of the reasons why the study is only available at limited number of centers.
Right. Mm-hmm. Thank you, Dr. Morgenstern. I have one last question before I jump into with the panel discussion and invite the patient advocates here. Dr. Morgenstern, this is for you. So if this treatment gets approved sometimes down the line, then would you expect to give the treatment and then still put a patient on maintenance, or would you expect to give the treatment and the patient does nothing until they progress?
Yeah, I think it's a very complicated question, and the honest answer is I have no idea. I think we're at a fairly early stage of developing this drug at the moment. I think we need to wait to see, first of all, what the safe dose is from the results of the first part of the phase 1 study, and then crucially we need to know, is this something that will work across multiple cancer types, or will there really be specific cancer types that it works better for, and that then it's best to pursue its development in specific cancer A or specific cancer B, as compared to at the moment a whole range of different cancers. And then beyond that is the question of, if it's effective and it's effective in a particular cancer, how does it compare to other standard treatments? And a lot of that will depend on a combination of how well it works, but also what the burden of treatment is and what the side effects of the treatment are, and how that compares to the current standard treatments that we have available. So I think the honest answer is at the moment is that it's too early to say. I think most likely the next step will be that we will further test the drug in patients whose disease has not responded to previous standard treatments, and where we're again trying to test this new treatment and see how well it works once we've established what the safe dose is. I just don't think we know. That was a long way of saying I don't know.
Thank you. No, absolutely. I totally agree. It's too early to say for us anything, right? With that, I will. Yeah, go ahead, doctor. You want to say something?
Yeah, I just wanted to add also to what Dr. Morgenstern just said. We have learned over the last almost 30 years or more than that, actually, with MIVG, that we don't really know at what time also we should use these types of treatments. So, of course, most phase 1 studies are done in a setting where there is no other curative option. However, these types of treatments, you could also imagine using them at other times, for instance, in upfront treatment for patients that do not respond well to our standard treatment. So there's a lot to learn when to use these type of treatments, at what time. And obviously, that comes later after we know the side effect profile and the dosing, obviously, the recommended phase 2 dosing for CLR 131 and any of these types of treatments. So as Daniel pointed out, it is very tough to say at this point in time, but I'm sure we will learn a lot down the road.
Absolutely. Thank you, doctor. With that, I will not keep the patient panel waiting anymore, and I will now invite Mark Unger to join the discussion. Mark is board member of Band of Parents, a nonprofit organization that funds innovative research and clinical trials for neuroblastoma. Mark's son was diagnosed with stage 4 neuroblastoma at the age of 3. Mark, please go ahead and ask your questions, please.
Thank you, Shweta. So yes, I'm on the Band of Parents. We've been an organization that's founded by parents, hence the Band of Parents. I'm not sure if you're aware of us as an organization, but we've supported clinical trials for neuroblastoma of more than 10 million over the last about 12 years in various different organizations. And the primary one being Sloan Kettering, where many of the children were treated. The reason that I'm interested in this treatment and wanted to find out more about it, because my son was diagnosed in 2001 with stage 4 and did well. We went first at Yale, then we went to Sloan Kettering, where we received the N8 protocol, which included the antibodies that Sloan developed, and was the reason that we went there. In 2003, a year later, he was clear of cancer, and then about 6 months later, he relapsed with a brain tumor. At that time, the standard of care was essentially resection and radiation. And we were told by the lead doctor, Dr. Chung, at the time that there was there's really no cure for a brain tumor relapse of neuroblastoma. Fortunately, with some work on my side in terms of looking for alternatives, we were able to locate one directly at Sloan, actually run by the pediatric team, that used radio-labeled antibodies, but that were administered intrathecally. In other words, they put a hole in my son's head with a port, and then that was delivered, but he did not have any more solid tumor. The tumor was removed. He did have leptomeningeal spread at the time, so he was not doing very well. And they did again, the same antibodies they used in his body, which helped clear his cancer there, were designed then with this I-131, the same, I assume a similar isotope, and they also used an 8H9, which is a little different one. And the theory was that the antibodies would wash the brain attached to whatever's floating around the cancer cells, and I'm not a doctor or a layman. And then those antibodies would, once they were attached, release the radiation and kill the cancer cells. And all this radiation would actually flush out of the brain spinal fluid within 24 hours and not have a major impact like beam radiation did, which he had as well. And so he was the first child to survive this relapse. And now is the standard of care at Sloan Kettering, and actually Y-MAPS, which is a publicly traded pharma company, is trying to get this drug really approved by the FDA as well for treatment. So, but I always think that there's probably other treatments, maybe because this one doesn't have to be invasive to the brain in terms of it goes through the blood-brain barrier, that you don't need to have the Ommaya port and all that kind of, which my son still has today. He's 23 now, but I'm relatively dangerous when it comes to medical information, so that may not be 100% on point. But in order for this treatment to be used, do you need to resect the whole tumor? Because my son's tumor was, like golf ball size, and so that means that whatever you're using, the transportation vehicle, as well as on the radiation, is that able to actually remove the tumor and kill the tumor over a short period of time?
Yeah.
Whereas resection needed.
So thanks so much for the question and the background. I think I'll answer your question, but just to kind of clarify the background, because I think actually it's really useful. In a way, there are now multiple products or multiple drugs that use the same type of technique to try and deliver targeted radiotherapy. And one of those that you've mentioned is omburtamab, which is tagging the radiation onto an antibody. Then there's CLR 131, which is tagging the radiation onto this PLE. And then there's MIBG therapy, which is tagging the 131 iodine, the radiation, onto MIBG, another molecule. So in a way, actually, the business end of it is the same for all of these, which is radioactive iodine. It's just about differences in the molecule to attach it to the cancer cells. And I think the answer again is going to be to your specific question about whether we need to resect the disease. We don't know in the specific instance of CLR 131. I think what I would say is that what we know from MIBG therapy in neuroblastoma is that the therapy works much better for disease in the bone and the bone marrow than it does for large soft tissue masses of tumor, which is probably to do with the extent to which the MIBG is able to penetrate into the tumor. And I wouldn't be surprised if similar things are true for CLR 131. Although on the other hand, I think, Dr. Otto, we've got data now suggesting that the CLR 131 does get into the middle of tumors, at least on the basis of imaging. And I think specifically for patients whose neuroblastoma comes back in the brain, which is a relatively unusual circumstance, but definitely one that needs particular treatment, it is intriguing that CLR 131 crosses the blood-brain barrier and so could be given into the blood and yet still potentially treat disease in the brain. I'll let my colleague add.
Yeah, no, I totally agree. I think we don't know how this will be panning out and whether we will need to remove first tumor. But again, what we know from most solid tumors is that as much as you can remove initially, the better, it is for treatment. But we don't really know this for sure for targeted radiotherapies. There may be actually a reason to not, remove everything or leave it actually the way it is, just because of cross-firing effect, where the radioactivity can actually treat from one cell across many cells, actually a cell that's further away. And so we don't really know that. For most other treatments like immunotherapies or chemotherapies, we try to remove large tumors when we can get to them safely.
Thank you. And I did want to mention that, so thankful for you doctors out there that are trying to, try to do the impossible and find new areas to save our children. I know it's not an easy job. On the technical side, I did watch that little 1.5 minute YouTube video, which was pretty cool. It's a simple way to understand the technology. But could you explain again, how does the PLE and these lipid rafts actually find this part of the cancer cell that's unique and bind to it? Is that a man-made thing that look pretty man-made on the video, but is it naturally occurring? How does that actually work in kind of a layman's terms?
Yeah, so that port of entry, these so-called lipid rafts, are actually on pretty much every cell. However, in tumor cells, they're much higher expressed to a much higher extent. And the lipid rafts are part of the cell membrane. And they are composed of a high amount of sphingolipids and cholesterol, and are naturally already an entry point for a variety of types of fatty acids. And in essence, PLEs are long-chain fatty acid mimetics. And tumor cells, when they grow and particularly when they get more aggressive, they undergo a metabolic shift, and that increases their needs for lipids and cholesterol molecules that can produce energy, help them build new cell membranes because they divide so quickly, and they also serve as basically an island of signaling. And the PLEs are therefore transported into the cell via some active and passive transport mechanisms like pumps. We call them flipases. And then what happens is actually they go inside the cell, and then they bind pretty quickly and integrate themselves into the cell membrane and other intracellular structures, basically like a brick into a wall. And there they sit, and they don't have to actually, they don't actually disappear very quickly. They sit there really like a brick in the wall. And since they carry the radioactive iodine, that radioactive iodine is not going to be released at all. It's just sitting with that molecule. And because it is so close to the DNA in the cell nucleus, where damage needs to happen to kill a cell, this is how basically it works. They're just sitting there irradiating the nucleus of that tumor cell, as well as surrounding tumor cells.
Oh, okay.
Does that make sense?
Yeah, it does. It does actually.
Yeah. And radiation in general, ionizing radiation breaks up DNA, what we call double strands, and causes double-stranded breaks in the DNA, and that is often not repairable by a cell, and the cell, needs to die then.
So the actual PLE is almost like food for the cancer cell.
Exactly. It's a natural, basically an analog of a naturally occurring building block of cell membranes.
Very cool.
Dr. do we know much about how it varies between different cancers? How much of the PLE they take up, how much rafts they have?
Yeah, so there are differences, at least in vitro. You know, in the test tube, we can see that there are different amounts of lipid rafts in cancer cells. However, we had looked at pediatric cancers, and we were actually surprised that not always does the amount of lipid rafts that's expressed in different cancer cell types correlate with the uptake. So there may be other ways that some other active pumps that are there in cancer cells transport this besides lipid rafts. So besides being located in lipid rafts. So I think lipid rafts are probably not the entire answer to that puzzle.
So have you, this phase 1 clinical trial, does that include neuroblastoma patients?
So neuroblastoma patients are eligible for the trial. And to my knowledge, though, I'm not sure whether we have actually currently actively enrolled a patient. I have enrolled a patient with neuroblastoma.
We treated a patient here. And I think the challenge for enrolling neuroblastoma patients is that MIBG therapy, which is, as we've mentioned, another form of radionucleotide treatment, so very similar, has been around for a long time and has obviously got a very long and reasonably good track record in neuroblastoma. And so in terms of the kind of pathway of decision making for a patient, if they're a patient who's suitable for MIBG therapy, it's probably difficult at the moment to recommend CLR 131 as an alternative, because that is at the stage of us learning about the dose, whereas the MIBG is at the stage of us having a dose and knowing much more about it. And so really it's more likely to be relevant for neuroblastoma patients who have disease that doesn't take up MIBG, because then potentially it might take up the CLR 131.
Right. Understood. So what primary pediatric cancers have you had on the trial, and would have, and I don't know how long the trials lasted, but would have been any results so far?
Yeah, again, I think, this is an ongoing trial, so results on the efficacy of the drug haven't been released yet. So even we as investigators don't know really, how other patients at other institutions fare. And it's too early to say, because we are also still in that dose finding phase where we increase the dose with every patient cohort. And so efficacy hopefully will also go up. The more radioactivity you can actually inject, and the more is tolerated with the patients. But there were a variety of patients with brain tumors, as I mentioned, DIPG, medulloblastoma, a couple of other brain tumors, and a variety of solid tumors such as Ewing sarcoma and some very rare sarcomas as well.
Mm-hmm. You said you only had how many total patients across all the sites have been on the treatment or on the trial so far?
That is a good question. I assume it's probably by now about 12 or 13, Daniel.
I would say it's probably something like that, yeah. I don't know the exact number. Yep.
Yeah.
13. Yeah. All right. And then you said there have been minor side effects, or what side effects have you had so far besides fever, nausea, the usual? Well, what my son had also, kind of high fever, nausea.
I think fever is. Oh, Daniel, you go ahead. Sorry.
I was just going to say. I think from our experience here, the actual infusion itself is extremely well tolerated with minimal side effects, if any. The biggest challenge is the effect on the bone marrow afterwards, especially as we get into the higher doses, because one of the challenge of radionucleotide therapy is you're putting radiation into the body. And what you're relying on is you're targeting to take the radiation to where you want it to go, which is the cancer, and for it not to go elsewhere in the body, which is the bone marrow especially. But if the cancer is close to the bone marrow, if the cancer is actually in the bone marrow, then it's very difficult. And so, I think for us, the main toxicity we've had is the effects on the blood counts, the low neutrophil count and the low platelet count after the treatment, rather than actually any challenges at the time of administering it. Sorry to.
I see.
Yeah, and I think the other part to that story is also that many of these drugs, and particularly CLR 131, is fairly highly bound by proteins in the blood before it's actually taken up into the cell. So it actually circulates for a couple of days in the bloodstream, and while it's doing that, it also bypasses the bone marrow. And so, although there may be patients who do not even have a bone marrow involvement of their cancer, it still will bypass and kind of travel alongside the bone marrow, just because bone marrow is very full of blood and will radiate the bone marrow, and then you will have the effects that Dr. Morgenstern mentioned.
Do you find that a good amount of the dose gets into the brain, or is it whatever the percentages in the body is also found in the brain of the PLEs? And
so that's what we call, this is also a fantastic question. There is a part of this study that we didn't talk about because it's rather a technical part of the study. So some patients will actually qualify to take part in a dosimetry study. And dosimetry, what that means is we want to know how much of the injected dose of radioactive compound actually goes to the tumor and which one does not, and eventually is gonna decay and is excreted. That's part of the dosimetry study, and that will actually exactly tell us how much goes to, let's say, a brain tumor or a tumor that's located somewhere else in the body, in the abdominal cavity, or metastases in the lung, for instance. But we don't have that data yet, at least not in pediatrics.
Understood. Thank you.
Thank you, Mark. Next up on the panel, we have Jeremy Piver. Jeremy was diagnosed with brain tumor at the age of 12 with a recurrence at age 23. And he is undergoing experimental treatments for the new tumor growth due to the rare molecular makeup of his tumor. And he advocates for brain tumor and young adult cancer communities through writing, speaking, fundraising, and lobbying. Jeremy, please go ahead.
Thank you, Shweta, for having me, and thank you, all of you, Dr. Morgenstern, Dr. Otto, and also Mark, for all the work you do. Shweta outlined a little bit of my history, but just to give a clearer picture, I was diagnosed with a oligodendroglioma back in 2004 when I was 12 years old, and at that time, the standard of care was, as you said, resection and radiation, but we really didn't want to pursue radiation because of potential long-term side effects, which I'll bring into one of my questions in a little bit. But then, and I was great for 10 years after having resection, but then in 2014, when I was 23, I had a recurrence. And so at that time, the standard of care was now Temodar, and rather than standard radiation, I did proton beam radiation. And I entered actually medical school, and 9 months into then I had another recurrence. And this time, back when I was 23, surgery wasn't actually an option because the tumor was in the motor sensory cortex. And so it was too dangerous to operate there. But then when I had my recurrence when I was 27 in 2018, there was a part that I could resect and via awake brain surgery. And once they did pathology on that and genetic testing, they saw that it had advanced to a anaplastic oligodendroglioma. And given the life history and also the unique molecular characteristics, which I won't go into now, I wasn't really qualified for lots of classical clinical trials. And so we had to pursue completely different experimental course and tried precision therapy with IDH targeted molecular therapies that were approved for other cancers, but did it off-label, which didn't end up working on its own. So then we did another round of radiation, this time just standard radiation, along with immunotherapy, which I continue on those treatments until today. But of course, I was going through this, kind of trying to stay up to date on the next clinical trials, because it's not an if I get another recurrence, it's about when. And so a lot of my questions, well, I'll have some about the molecular topics or the medical topics we discussed. I do have some just general questions about considerations with clinical trials. And so my first one is to Dr. Otto, what are the considerations, especially with a child, when parents are the direct decision makers, that parents should consider, but also when you are a child. I was 12 years old, and while I was still a kid, I really wanted to be part of that decision-making process. So what considerations should patients, when they're old enough, but also parents, take when deciding to do this treatment option, or if there's spot open considering this clinical trial versus another treatment route?
Jeremy, very good question. Thanks for sharing your story. I would say, gladly nowadays we have numerous new options for the treatment of relapse and refractory solid tumors and brain tumors. And there are also many phase 1 studies, as you mentioned, out there. I think, it's difficult because there are many individual criteria that you have to consider when choosing treatment options for a particular patient with a relapsed cancer. And frankly, we take a lot of time to discuss all the pros and cons of available studies with families. And that means really parents and patients. And also we consider their quality of life, which is also very, very important. Cure is not always achievable, but if it is, then you also want to consider quality of life when you decide on different treatments. Now, I would say one important consideration parents and patients should consider when you choose CLR 131 is probably a couple of things. First, you need to adhere to radiation safety practices and the initially necessary patient isolation. And sometimes a younger child that's particularly anxious and clingy may have really a difficult time with a limited contact to a mom or dad. It might not be really just for that purpose a good candidate for that type of treatment. Another one is having obviously a pregnant primary caregiver, which would pose a similar problem. And then, of course, what Dr. Morgenstern already mentioned previously was the ability to collect stem cells prior to the treatment, maybe a technical challenge, particularly in very heavily pretreated patients, which our patient population with solid tumors very often is. Now, on the other hand, I would say the treatment itself is relatively straightforward and has limited inpatient time compared to some other treatments. CLR 131 is radiation therapy and not chemotherapy. And many relapsed tumors and cancers are fairly resistant to a lot of chemotherapies we already gave. And so, targeted radiation therapy such as CLR 131 could have a distinct advantage over some of these other treatments. But it is a very difficult decision. We spend a lot of time in talking to families and patients. And obviously you have to child appropriately talk to your patients, right? And explain what's going to happen with any type of a treatment. But I can say that I'm always very humbled and very impressed about how adamant patients, even young kids, can be about their treatment and what they would like to have, and also being very open to say what they don't want to do. And so this all has to be put in consideration when you recommend or when you discuss treatments with patients.
Thank you for that, Dr. Otto. And my next question is, kind of part of one of these considerations, and something I've had to consider, especially when I did my second round of radiation, are about the long-term side effects of radiation. And one of the reasons I didn't do radiation when I was 12 years old is my parents and doctor were concerned about, especially with children, the amount of time you have after treatment, the long-term side effects that can develop, whether that's learning disabilities, physical disabilities, but also secondary malignancies. And what do we know about CLR 131 and those potential considerations, if any? And sorry, that was directed to Dr. Morgenstern.
So again, it's a great and very important question. I think the honest answer is we just don't know at the moment, because our total duration of experience of this drug in pediatrics is only a year or two at most. So we'd be pretending we knew something that we didn't if we said we knew exactly what the late effects were. I think we know from MIBG therapy in patients with neuroblastoma that there is an increased risk of secondary malignancy in patients who have MIBG therapy, although it's difficult to separate that out from the increased risk that comes from all of the other components of the treatment and from having had a childhood cancer at all. And in terms of the radiation, and especially for brain development, we know, as you've highlighted, that there are challenges with neurodevelopment, especially in young children, especially under the age of 3, who have external beam radiation to their developing brain. And I think, honestly, we don't know what the impacts of this will be. I think, You could argue that hopefully the impacts of this will be less because potentially it's more targeted, that the radiation is more focused on the tumor. But I just honestly think we don't know that at the moment. And I think it's something we've got to be aware of. I mean, I think unfortunately it's one of the challenges of how we develop new drugs is that honestly, at the moment, our focus for the study is on short-term toxicity, because if we tried to have the long-term toxicity as the outcome measure of the trial, it would never get finished. But on the other hand, clearly it's very important that is borne in mind in the future development of the drug.
No, that makes a lot of sense. And Dr. Morgenstern, just as kind of a follow-up, when used for brain cancers, you might not know this yet just because of the 2-year time scale, but oftentimes, even on a short-term scale, these radiations can cause inflammation, and that's something to be considered in the brain, depending on where it is. Like for me, that's a big consideration because it's in the motor sensory cortex. And so, when I have my radiation, I get lots of seizures, especially right after. And so is that found with this, or does that cause inflammation?
I think that's a great question. From my personal experience, I don't think we've seen that as a challenge so far. I don't know, Dr. if you can remember from the central data whether there have been patients who've needed steroids post-therapy because of radiation-induced inflammation or not.
Yeah, no, I'm not aware of that at this point in time, but it's entirely possible that when we reach higher doses, that this may be, important to consider and give patients steroids. But at this point in time, we don't know that yet.
Mm-hmm. Thanks. And then my next question is kind of more related to roadmaps, because oftentimes with, once you get to this point of decision-making with clinical trials or experimental treatments, you're not just focusing on, okay, what's just my next treatment, but, you have different treatment options. You're thinking about down the road too. And sometimes certain treatments prevent you from considering other treatments in the future. For example, in 2014, it was in 2018 recurrence. It's a long history. I ended up not doing the next standard chemotherapy, one, because of a molecular part of my tumor that would make me not as likely to respond to it, but two, because if I wanted to do immunotherapy, it would affect the efficacy of the next treatment option I wanted to do. And so do you know with this treatment, how it might affect the efficacy of other treatments down the road, and also about the ability of participants to participate in clinical trials of other types of drugs in the future? And is that a consideration you tell patients? And Dr. Otto first, and then maybe Dr. Morgenstern, if you have something to contribute.
Sure. So excellent questions, Jeremy. And I guess in general, as is the case with most phase 1 studies, patients while they are on study cannot receive in parallel, other forms of cancer-directed treatment, just simply because you would, interfere with the safety aspect of the study, where you don't know which drug would, cause a safety issue. For CLR 131, the only exception is probably focal radiation to a progressive tumor spot in the body. So large radiation is large area radiation is not allowed, but spot radiation would be allowed. Now, that being said, parents and patients can always, change their mind about trial participation. And if a patient experiences progression while on study, there is clearly, always the way to say, the patient goes off study, receives a different form of treatment. Now, whether they're eligible at that time for that particular treatment depends a little bit on that particular treatment and the eligibility criteria for it. The observation period from our, from a clinical trials perspective of the CLR 131 study is a total of 75 days. So after that, patients are always free to also pursue something else down the road if a tumor, of course, progresses, or if there's any other reason that that a patient wants to have some form of a maintenance therapy. Just not during these 75 days of observation period. That's for the safety perspective. It's very difficult to say, I would not anticipate for the majority of trials that that this could be interfering with eligibility for them, unless it is, in a time frame that's so early that there's still radioactivity on board, So that may preclude also just for radio safety purposes, that may preclude participation, or at least postpone it until the radioactivity is completely gone.
Yeah. Or
does that answer your question?
I mean, I think at higher doses, I think the other thing to take into consideration is the blood counts, and the most phase 1 studies.
Correct. Yeah. And
blood count levels. And so it may be that patients have to wait for their counts to recover to that threshold to be eligible for a subsequent study.
That's right. Yeah. Very important one.
That makes sense. Thank you. And then my final question, maybe Dr. Morgenstern first and Dr. Otto, I'd like both of you to answer is, zooming out a bit just from CLR 131, what would you say to a parent who is concerned about having their child participate in experimental treatment? And also, what would you say to the child as well?
What a wonderful and challenging question. I mean, I think it's something I spend a lot of time thinking and worrying about. And I think I see my role as mainly to make sure that I honestly share the information that I have available. I think it's very important that patients, parents, and as much as possible, depending on the age appropriateness, the child know what they're getting into and the level of confidence that we, as the clinician, have as to whether it will work or not. I mean, there are some things that we offer that are clinical trials, but actually it's only a clinical trial in name, but realistically, we have a very strong expectation that it's going to work and will be of benefit therapeutically. And there are other trials that are at the other end of the spectrum when it's a very new type of treatment. And we have to be honest with families and say, we just don't know whether this will work or not. We have no previous information from patients with this disease of this working. I'm offering this to you because I can't offer you a better option. And I think, that finding that balance about giving the information and being realistic about the likelihood of benefit, I personally find really important. And then I try and, help the family, depending on what they want, to work through the decision-making process. I mean, I think in the, as it were, the bad old days of medicine, the doctor knew best and the doctor told the patient what to do. I think the pendulum swung very much towards, patient empowerment, which I think is absolutely appropriate. I sometimes worry it swings so much that it's sort of the medical team washing their hands and saying, well, we don't know what to do. You decide what to do. So personally, I think we have to find a balance, and it varies from family to family, I think, as to how much guidance they want. And clearly, ultimately, enrolling in a clinical trial is, the family decision, and our responsibility is to make sure they have as much information. And I think from the patient perspective, it really depends on the age and the experience of the patient. I mean, a lot of the patients that I talk to for early phase trials have been through years and years of treatment and are actually super expert on everything, even if they're 10, 9, 12 years old, and completely different from taking a 9-year-old patient off the street who's had no interactions with hospitals. So I think it just comes down to the individual and try and personalize the discussion.
And Dr. Otto, do you have anything to add to that?
Yeah, no, I mean, everything that Dr. Morgenstern said is, exactly what, what my, experience is as well. And also my personal goal when I talk to families. And, one part is really the important one. We are the experts. It is what it is. So we have to also take that responsibility and, expertly educate our families and also dive into new treatments that have come up, and sometimes also dive into preclinical data and make up our own minds. Do we feel, that we feel comfortable offering a certain study to families? That is our responsibility. That's what we, go to school for a long time. And that's what parents and families should expect from us. That's one part. The other side of the medal is, of course, that, all standard of care treatments that we use to cure kids with cancer once started as an experimental therapy. We have to be as open to that as well, right? And they all started as, or the majority of those started as early stage clinical trials. And so it's the nature of these experimental treatments that we don't know yet all the potential side effects and whether all patients will benefit from the treatment or if any patient actually benefits from treatment. So we just have to be also very clear to families about that. And if treatments show promise in preclinical work and in the test tube in animal experiments, we hope that they hopefully, we hope that they show benefit in patients as well. and that they are safe and well tolerated and have an acceptable side effect profile. So that's in essence, what I explain also to families when they have to make this decision. Do I want my child to participate in, or us as a family participate, in an experimental treatment?
Thank you both for all the work that you do, and thanks for answering my questions so well.
Thanks so much.
Thanks, Jeremy.
Thank you.
Great questions. Yeah. Thank you, Dr. Otto, Dr. Morgenstern. It was a great session, and thanks for all the information shared. And we hope CLR 131 proves to be instrumental in improving the prognosis and survival rates for pediatric cancer patients in the coming years. And Mark and Jeremy, thank you for your time and your questions. And it's been a very informative discussion we had. And it was a pleasure talking to all of you. So this talk will be available on Cure Talks and Selector websites and YouTube channels. Until next time, thank you everybody and have a great day. Stay safe.